So guys, this is our last topic for the midterms before finals.
And our topic is about diuretics and antihypertensive.
So let's do the introduction.
Go Maan!
Kaya mo
guys,
yan.
let's do this. For the topic diuretics and antihypertensive, this chapter will discusses the wide variety of drugs now employed for the management of hypertension. The diuretics, even though a separate drug class, are actually among the most important and frequently used as hypertensives. In hypertensive, hypertension is defined as either a sustained systolic blood pressure or greater than 40 mmHg or a sustained diastolic blood pressure of greater than 90 mmHg. Hypertension results from increased arteriolar resistance and reduced capacitance of the venous system. In most cases, the cause of the increased vascular tone is unknown.
There are two types of hypertension, the essential and the secondary. For the essential, it is a disorder of unknown origin affecting the blood pressure regulating mechanism. Essential hypertension specific cause unknown as essential or idiopathic. For the secondary, it is the secondary to order disease processes. Causes is known such as eclampsia of pregnancy, renal artery disease, and phenochromocytoma. Diuretics can be used as first-line drug therapy for hypertension unless there are compelling reasons to choose another agent. Low-dose diuretic therapy is safe, inexpensive, and effective in preventing stroke, myocardial infarction, and congestive heart failure, all of which can cause mortality.
So now let's go to normal regulation of blood pressure. So according to the hydraulic equation, arterial blood pressure is directly proportionate to the product of the blood flow and the resistance to the passage of blood through precapillary arterioles. So the equation is the BP is equals to CO times PR. So postural barre reflex. So barre reflex are responsible for rapid moment-to-moment adjustments in the blood pressure, such as transition from reclining to an upright posture. So the reflex increases in sympathetic outflow, acts through nerve endings to increase peripheral vascular resistance and cardiac output. So next is the renal response to decreased blood pressure. So by controlling blood volume, the kidney is primarily responsible for long-term blood pressure control. In addition, decreased pressure in renal arterioles are as well as sympathetic arterial activity via stimulates production of renin, which increases production of angiotensin. So the causes of angiotensin is direct constriction of resistance vessels and stimulation of aldosterone synthesis in the adrenal cortex, which increases renal sodium absorption in intravascular blood volume. So vasopressin, released from the posterior pituitary gland, also plays a role in maintenance of blood pressure through its ability to regulate water reabsorption by the kidney.
For the basic pharmacology of antihypertensive agent, there are four categories: the diuretics, sympathoplegic agent, direct vasodilators, agent that blocks production or action of angiotensin. For the diuretic, it lowers blood pressure by depleting the body of sodium and reducing blood volume and perhaps by other mechanism. For the sympathoplegic agent, it lowers blood pressure by reducing peripheral vascular resistance, inhibiting cardiac function, and increasing venous pooling in capacitance vessels. For the direct vasodilators, it reduces pressure by relaxing vascular smooth muscles, thus dilating resistance vessel and to varying degrees increasing capacitance as well. For the agent that block production or action of angiotensin, it reduces peripheral vascular resistance and blood volume. diuretics, it is an agent that increases urine volume, whereas natriuretic causes an increase in renal sodium excretion and an aquatic increases excretion of solute-free water. It can be used as first-line drug therapy for hypertension unless there are compelling reasons to choose another agent. Low-dose diuretics therapy is safe, inexpensive, and effective in preventing stroke, myocardial infarction, and congestive heart failure, all of which can cause mortality.
So, what are the uses of the diuretics? So, first, of course, is the thiazide diuretics, loop diuretics, potassium-sparing diuretics, osmotic diuretics, and of course, the vasopressin.
Okay, so you've mentioned about the thiazide diuretics. So the use of this is all oral diuretic drugs are effective in the treatment of hypertension, but the thiazide have found the most widespread use. So what is the possible action of this thiazide diuretics? Such as hydrochlorothiazide. It lowers blood pressure initially by increasing sodium and water excretion. This can cause a decrease in extracellular volume, resulting in a decrease in cardiac output and renal blood flow.
So, let's now go to the therapeutic uses of it. So, thiazide diuretics decrease blood pressure in both the supine and standing position, and postural hypertension is rarely observed except in elderly, volume-depleted patients. Of course, these agents counteract the sodium and water retention observed with the agents used in the treatment of hypertension. So, thiazides are therefore useful in combination therapy with a variety of other antihypertensive agents, including the B blockers, ACE inhibitors, angiotensin receptor blockers, and potassium-sparing diuretics.
For the pharmacokinetics, diuretics are orally active. Absorption and elimination rates vary considerably, although no clear advantage is present for one agent over another. And all thiazide are ligands for an organic acid secretory system of the nephron, and as such, they may compete with uric acid elimination.
So what is the adverse effect of thiazide diuretics? It includes hypocalcemia and hyperuricemia in 70% of patients and hypoglycemia in 10% of patients. So hypomagnesemia may also occur.
So the other diuretics are the loop diuretics. So the loop diuretics act promptly even in patients with poor renal functions or who have not responded to thiazides or other diuretics. And lastly, the potassium-sparing diuretics. Amiloride and transference of epithelial sodium transport at the late distal and collecting ducts, as well as spironolactone and eplerenone reduce potassium loss in the urine. So the osmotic diuretic agents alter the water excretion.
For the last diuretics, which is the vasopressin or the antagonist, is used in the treatment of central diabetes insipidus, and it is divided into two, the conivaptan and tolvaptan. The conivaptan, it reduces water reabsorption, increased plasma sodium concentration, vasodilation. And for the tolvaptan, it reduces water reabsorption, increased plasma sodium concentration.
So, drugs that alter sympathetic nervous system functions are the methyl-dopa,
Guanethidine,
And guanidrel.
For the methyl-dopa, it is widely used in the past but is now used primarily for hypertension during pregnancy. It lowers blood pressure swiftly by reducing peripheral vascular resistance, which a variable reduction in heart rate and cardiac output.
So the second one is guanethidine. In high enough dose, guanethidine can produce a profound sympathoplegia.
So the last one is the guanadrel. It's a guanidine-like drug that is available in the USA, betanidine and debisorphan. weak, antihypertensive agents are available for clinical use in the USA as similar.
So what are the mechanisms and sites of actions of those diuretics? Guanethidine inhibits the release of norepinephrine from sympathetic nerve endings. Also, is transported across the sympathetic nerve membrane by the mechanism to transport norepinephrine itself. And uptake is essential for drug action.
So, what are the pharmacokinetics and dosage? So, because of guanidine long halves, the onset of sympatologia is a gradual, and sympatologia persists for a compatible period after cessation of therapy. So, the toxicity is guanidine induces sympatologia. In men may be associated with delayed or retrograde ejaculation. Guanidine commonly causes diarrhea.
For the reserpine, an alkaloid extracted from the root of an Indian plant, Rauvolfia serpentina, was one of the first effective drugs used on a large scale in the treatment of hypertension.
For the mechanism and site of action of reserpine, reserpine blocks the ability of adrenergic vesicles to take up and store biogenic amines, probably by interfering with the vesicular membrane-associated transporter. And this also occurs throughout the body, resulting in depletion of norepinephrine, dopamine, and serotonin in both central and peripheral nerves.
So the toxicity. So reserpine produces little postural hypotension. Most of the unwanted effects of reserpine results from action on the brain or GIT. High dose of reserpine characteristically produce sedation, lassitude, nightmare, and severe mental depression. Occasionally, this occurs even in patients receiving low dosage.
And lastly is propranolol. It was the first beta blocker shown to be effective in hypertension and ischemic heart disease. All beta adrenoreceptors blocking agents are useful for lowering blood pressure in mild to moderate hypertension. And in severe hypertension, B blocker are especially useful in preventing the reflex tachycardia that often results from treatment with direct vasodilator.
So, the mechanisms and site of action. So, propranolol's efficacy in treating hypertension as well as most of its toxic effects results from non-selective B blockade. Propranolol inhibits the stimulation of renin production of catecholamines. So, the pharmacokinetics and dosage. Propranolol can be administered twice daily and slow release once daily preparations are available. So lastly, the toxicity. The peripheral toxicity of propranolol results from blockade of cardiac, vascular, and bronchial receptors.
So there are 4 toxicity of diuretics. The first one is in treatment of hypertension, the most common adverse effect of diuretics, except for potassium-sparing diuretics, is potassium depletion, in which potassium loss is coupled to reabsorption of sodium, and restriction of dietary sodium intake therefore minimizes potassium loss. Diuretics may also cause magnesium depletion, impair glucose tolerance, and increase serum lipid concentrations. And the last one is diuretics increase uric acid concentration and may precipitate gout. For the metoprolol and atenolol, these are drugs that are cardioselective and are most used in beta blockers in the treatment of hypertension. For the nadolol, carteolol, metaxolol, and bisoprolol, nadolol and carteolol are non-selective beta receptor antagonists, are not appreciable metabolized, and are excreted to a considerable extent in the time. Metaxolol and bisoprolol are selective beta blockers that are primarily metabolized in the liver but have long half-lives.
In pendolol, acebutolol, and penbutolol, those 3 are partial agonists. They lower blood pressure by decreasing vascular resistance and appear to depress cardiac output or heart rate less than other beta blockers. Perhaps because of significantly greater agonists than antagonists, the effect at B2 receptors. Esmolol is the B-selective blocker, beta-selective blocker that is rapidly metabolized via hydrolysis by red blood cells esterases. It has a short half-life, which is 9 to 10 minutes, and is administered by intravenous infusion. Esmolol is used for management of intraoperative and postoperative hypertension, and sometimes for hypertensive emergencies.
For the minoxidil, this is very efficacious orally active vasodilator. The effect results from the opening of potassium channels in mouth muscles, membranes by minoxidil sulfate, the active metabolite.
In this report, it concentrated on the way how drugs are being used to control high blood pressure. The treatment of high blood pressure has become one of the greatest challenges for medical professionals today. So, dual renin system blockage give enhanced blood pressure lowering in patients with mild